Hey guys, thought I'd get started with our next section in positioning. We're just going to be covering the chest and abdomen. Um, there's a lot of information that we need to know in relation to the chest itself, so I thought we would kind of maybe go over that today, and I'll do another one over the abdomen. But I'm starting on page 87 in your book, and that's chapter 3. We're going to be talking about body habitus. And I do want to start sharing my PowerPoint, so give me just a second to find that. I think this will be a little bit more useful for us. Let's see if it's going to open up. Okay, so here we have the chest and abdomen. And on page 57 in your book, we may need to go back, and I know you've had this before, but as with everything in positioning, you're always going to be needing to know landmarks. And this is on page 57 again in your book. We've got the ones that are going to be really important is going to be your jugular notch, your sternal angle, which is B and C. A is not as relevant. That is C5, which is your thyroid cartilage. Then we got the ELF is going to be your xiphoid. Let me try something here. I said I could do this. I'm just going to see if we can make this work here. Okay, so again, we're looking at A, which is going to be your C5 or your thyroid cartilage. Here we're going to be looking at your jugular notch and your sternal angle. Okay, ones that are going to be relevant is there's E, that is the tip of the scapula, which corresponds to T7. So it's an inferior tip of the scapula. That's going to become important when we're doing our PA chest x-rays, because you're going to be able to palpate that when you're doing a patient standing and doing a PA projection of the chest. That is where your horizontal crosshair will go. Will be at the tip of the inferior angle or tip of the scapula, which correlates to T7. So, and then we have the xiphoid tip. And further down, we're going to go, and this is going to be really relating to the abdomen. Obviously, this is in the pelvic region, but you still need to know that this is L3, this is L4, and L4 corresponds to the very top of the iliac crest. Again, I may cover this when we do the abdomen also. We're looking at J. J is very, very important. It's called the pubic symphysis. It's at the very bottom of your, and right underneath your bladder. So we'll talk about that when we get to the abdomen and the KUB. On page 59, this is again something that you've been exposed to. I encourage you to go back. I want you to read this, get familiar with it. The reason that we do cover this again in our positioning class when we're talking about the chest and the abdomen, I'm sure everyone can appreciate. Look how different the lungs for the hypersthenic patient. The hypersthenic patient accounts for a relatively small percent of the population, but you see where their lungs are very short and broad, and you have very little of the apex above the clavicle. When you get to your sthenic population, this is 50% of the population. You're going to see that you have quite a bit of the apex, and this is called the superior aperture of the thoracic cavity. We'll talk about that in just a minute. But this lung is actually being pushed up above the clavicle and through the upper portion of the rib cage. Okay, so that's your sthenic patient. You have your hypo patient, which is 35% of the population. This one here kind of follows. It's the most difficult to really look at and determine what type of body habitus you're having when you're doing the chest x-ray, because it really does fall between your sthenic and your asthenic patient. Your asthenic patient, if you notice, look how long and thin, very thin, the lungs are. Why do we need to know this when we're doing a chest x-ray? In the olden days, when I was actually a clinician, we had to make determinations which way we were going to turn our IR. And of course, it was a 14 by 17 at that time. Were we going to do it lengthwise or crosswise? Well, obviously, this person, we would put it in lengthwise using the 17 inches this way in order to make sure that we got all the long of the lung here. And over here, we would put it crosswise because it's more broad. And so we would put them crosswise here, and then we do them lengthwise here. That is really why we're covering this right now. Now, with your DR plates, most of your DR plates come in a square. So this really becomes irrelevant, I guess you could say, but it's still important. And senior technologists have a tendency to always kind of, as you're walking your patient to the room, you're looking at him and you think, oh, I better go in there and turn my film the other way, my IR the other way. He's very, very tall. And I put it in crosswise because for the majority of the population, for these three categories here, normally we would put the film in, the IR in crosswise because they would fit. Obviously, this one is a give or take because it's wide as well as long, but not quite as skinny and long as your asthenic patient. But again, go back in your book on page 59 and over on to page 60. Read that information. It's interesting. It's necessary for you to understand body habitus. And again, we're doing this in relation to the size of the lungs. We're looking at the apical region and to see which ones actually you see the sthenic patient and your asthenic patient naturally have some of the apex above the clavicle, whereas your hypersthenic patient, there's no apical region of the lungs above the clavicle. And here again, these are your actual images of your patients, and this can be found on page 58 in your book, and you can see how this would definitely be a crosswise patient. This person falls into that hypersthenic category. This is the one, this is your hyposthenic. You're very tall, long lungs, so we would have to put our image IR in lengthwise. And these two here, again, you can see most technologists keep them in lengthwise because these do have a tendency to be a lot longer. But you can also see the problem when you get to these little costophrenic corners here. They're barely on there when you're putting them in. So like I said, you have to be extremely careful when you're placing these. Actually, I'm looking at C here. There's a problem right here because it's snipped, that costophrenic angle, and we have more space up here above the shoulders that we could have lowered our IR and our beam down just a little bit. I would have repeated this. This little costophrenic angle is very important, and we'll talk about that shortly. So anyway, on page 87 in your book, we're going to talk a little bit about the thoracic cavity. The thoracic cavity is bounded by the walls of the thorax and extends to the superior thoracic aperture. Again, this is that area I was talking about. There is actually an opening right here. This is your first rib. So as we inhale and exhale, this lung is able to expand superiorly and actually come through the rib cage here in this thoracic cavity. The thoracic cavity, I want to make sure you understand this. The thoracic cavity is the ribs and the sternum. So they're making a skeletal structure around of the lungs to really protect them and to support them. So that is what they're talking about when we have a superior aperture opening. It said it extends, and it says where structures enter the thorax to the inferior thorax. That's this entire area here. So we also have an area down here where the thoracic cavity is open, obviously the rib cage, if you want to call it. There's an opening down here, and obviously this here is your diaphragm. Your diaphragm is your muscular organ that helps push the air up and down in your lungs. So you have your inferior aperture, and then you have your superior aperture up here, and these are able to allow the lungs to expand. Okay, that's what we're bringing some emphasis to it. The mediastinum is actually your central portion located between the two separate lungs. Yes, the lungs are separate organs. So right between there's this area, this entire area called the mediastinum. and that is between the area of the two lungs, and this is where everything, all of your input and output, all your bronchial tubes, your heart, all your vascular areas, all of that is found here in the mediastinum, or they also call this the hilar region. Okay, so here, this is taken here with the front part of the chest, the thoracic cavity taken away. The one thing I want you to appreciate here, again, you can see where they have the mediastinum. This is the mediastinum, or the hilar region. I want you to look here and see, we got what they call a horizontal line going here. And this is with the right lung only. Notice there's nothing over here on the left. So what's unique about the right lung is that it has 1, 2, 3. It actually has 3 lobes compared to the left lung, which only has 2. So that's one thing unique, and that's one thing you will need to know about the anatomy of the lungs. I'm reading on page 87 in your book. It says the diaphragm separates the thoracic cavity from the abdominal cavity. So obviously underneath the diaphragm, you're going to have your stomach. You're going to have your small intestines. Your liver is going to be over here on the right side. So the diaphragm is actually separating the thoracic cavity from the abdominal cavity, which will be down here, and we'll be covering that with our abdomen and our KUBs. So let's see if I'm still on page 87. I want to make sure. And one thing on that third column there, it's talking a little bit about the thoracic cavity itself. Okay, it says the thoracic contains the lungs and heart, organs of respiratory, cardiovascular, and lymphatic system, the inferior portion of the esophagus, and the thymus gland. Within the cavity are 3 separate chambers. This is important. Within the cavity are 3 separate chambers, a single pericardial cavity, that's encasement around the heart, and the right and left pleural cavities. These cavities are lined by shiny, slippery, and delicate serous membranes. The space between the 2 pleural cavities are called the cavity between the 2 pleurals are called the mediastinum. Again, we've said that. So what you're actually telling us is that we have a pleural cavity right side, we have a pleural cavity left side, and then we have the mediastinal cavity in the middle, or the hilar region. We normally I call it the mediastinum. I've heard both words being used. The space between the 2 pleural cavities of this area contains all the thoracic structures except the lungs and the pleura themselves. Okay, and this is found on page 87 of your book. I'm using 2 different books here, so you have to excuse me. All right. The thalamus gland is something that we try to protect. That's part of the endocrine system. It's not something that we're really going to need to do any focus on as far as the x-rays of the chest. So we're just going to mention it. Obviously, you see where the thyroid gland is right there around the trachea. So that's why we always wear a thyroid protection, so that we can protect that with some lead. And here's your thoracic cavity, again, separated. This is all your abdominal cavity, and that is called your peritoneum. They call this the abdominal pelvic cavity. Pelvic cavity obviously is your encasement around your bladder. Your abdominal cavity is the area here in the blue, showing that it contains all of your intestinal tract, all of your liver, gallbladder, pancreas, spleen. Everything is enclosed in this abdominal cavity. And again, this is called the peritoneum. You have the left pleural cavity. You have the mediastinum, which is this entire area here in the middle. That actually, there's your pericardium, that's your heart. And again, we have the right pleural cavity. Okay, the respiratory system themselves, this is going to be on page, I think it's me find out what page we're supposed to be in, because I want to say it was on page 88 in your book. Yes. So the trachea itself, it says the trachea is a fibrous muscular tube with 16 to 20 C-shaped cartilaginous rings embedded in its walls for greater rigidity. It measures approximately a ½ inch in diameter and 4.5 inches in length. It's right in here. You see the cartilaginous rings. And one thing's unique about these, they're flat in the back. It says the cartilaginous rings are complete posterior or incomplete posteriorly and extend around the anterior 2/3 of the tube. The trachea lies in the middle of the body, anterior to the esophagus. So when you're looking at your chest x-rays, especially your lateral views, this is going to be in front of the esophagus. Okay, so think, and I always tell students this, think about this being in the front of the esophagus. So with what's all going on right now in our current events, people are being trached, put on a ventilator. Well, guess what? They're able to access the trachea without disrupting any of the GI tract, because the GI tract is actually found behind the trachea. So your esophagus is actually behind the trachea. I always said God was a very clever person, very, very clever man when he decided how to design the human body, because it would be definitely a lot more difficult to put a trachea in if the trachea itself was located behind the esophagus. But you'll be able to see this when we get to the actual imaging of the chest x-ray. So the one thing I want you to pay attention to here, and it's very obvious on our x-rays, the trachea should be filled with air, so it should be black. And there's an area right here, and it's called the carina. That is where your trachea bifurcates or breaks into two, divides into two separate areas, into your right and left main bronchi or bronchus. Here's your left bronchus and here's your right. And notice that they're kind of going obliquely, and then they're just going to continue to break off into your bronchioles. Here you got your terminal bronchiole, your alveolar ducts. And obviously, these are your alveoli here, the little grape-like structures. This is where your oxygen and carbon dioxide is going to exchange. And here again, it shows you you have your carina, you have your left and your right. We flipped it here because this is a posterior view. And again, you can see the heart and all of this area here. Again, that's called the mediastinum. We have a superior lobe, a middle lobe, and we have an inferior lobe. So this tells us that this is the right lobe because there's 3 lobes to it, whereas we have a superior and an inferior on the left. More images of the lungs. Again, we have what we call the apex of the lungs, which is an area that often students will clip that because they've lowered their IR into too low. If you clip the apex, you have to do a repeat. Again, you're looking at this horizontal fissure. Horizontal fissure is only found in the right lung because it's divided into 3 independent separate lobes. Okay, and this is the oblique fissure, which separates your medial to your inferior lobe. And one of the most important areas, and I want to bring it to your attention, is the cardiac notch. Notice how this lobe here has a little indentation. Well, that is for placement of the heart. So it conforms to the heart itself right there, and it's called the cardiac notch. And yes, you can see this at times on a good chest x-ray. Your costophrenic angles, you have costophrenic corners here, and what happens is, and we'll get to this in just a minute, I'm sure it'll be a picture, but right here is where your diaphragm is going to be. And as you inhale, these little angles, as they fill, we create a little corner, a little triangle, and that has to be included on every one of your images, every one of your chest x-rays. You have to get the costophrenic angle. Again, that's one of the most common mistakes students make, or in mispositioning, they clip, and it has to be repeated. Reason being, as a patient comes in, say they have pneumonia at the time, and it's just a little mild pneumonia with some fluid. Well, guess what? This isn't a dome. This is kind of on a hill. So where do you think the fluid's going to accumulate? It's going to accumulate in this little lower corner here, and it'd be just a little distinct straight line showing you that there is air up here in the lungs, black, and then you have a little area, a perfect little straight line showing you that an air fluid level exists. If you were to clip this, and they get misdiagnosed as clear lungs, and this pneumonia takes over and completely solidifies these lungs with fluid. So that's very important that we do get that costophrenic angle. The other thing I want you to pay attention to is, again, we talked about the apex, we talked about the base, and again, as you can see, there is this dome-looking area here. Both lungs have them. So you're actually going to have your inferior, or your anterior and your inferior. Right now they're calling them anterior and posterior. But when we get into our views of the lateral, these are going to be both angles. You got to get angles on the front. You got to get angles on the back. So you're going to have costophrenic angles on both of the back of the patient because, again, it creates this dome effect. So any type of fluid, it's going to either accumulate posteriorly in this corner or posteriorly in this anterior costophrenic angle here. So here we're showing what the movement of the lung happens when we're doing inspiration. When you're doing do a chest x-ray and a patient does not do a good inhalation, takes in a good deep breath, this is what you're going to get right here. And it's going to be 1, 2, 3, 4, 5, maybe 6 ribs. That's going to fail for a chest x-ray because we have to have, I think it's a minimum of 9. So if we get a good inspiration, we're going to get 1, 2, 3, 4, 5, 6, 7, 8, 9. And again, that's what you're wanting, but that's how much your lungs will actually move from exhalation to inhalation, deep inhalation. Okay, I want to just bring that to your attention because when we get into our breathing instructions for the chest x-ray, it is going to ask you to do on the second inspiration, so you actually have the patient breathe twice and take in a deep, deep breath. Okay, so here's the cardiophrenic and costophrenic angles. These are the angles that I was talking about earlier. As you can see, this is your dome. This is the diaphragm right here. But each lung itself has its own indentation right here. So what we end up with, we have our our costophrenic. Costophrenic meaning costa means rib, and phrenic means diaphragm. So we've got costophrenic angle, that little acute corner there, and we also have one, this is the heart. All of this right here is your heart. All of this is known as the mediastinum, okay? And I'm going to tell you, looking right down here, you can see going straight down. You see that gray right there? It's coming straight on down. And right here, it bifurcates. If you can barely see it coming this way, and then you can see it coming this way, that is going to be your carina. That's where the trachea is actually going to bifurcate or divide into your left and right. And this is your right side. This is your left. The heart is always on the left. Another thing, this is cardiophrenic. So it's a cardiac, heart, phrenic, meaning diaphragm again. So we have the costophrenic and we have the cardiac phrenic angles. The one thing I want to bring your attention to, look at this little bitty bubble of air. It's called the gastric bubble. It's high and it's underneath the diaphragm. That tells me, that's an indicator that this chest x-ray was performed erect because it is high in the stomach. Okay, we'll get to that later on. Okay, just another perspective of what all is included in the mediastinum. Again, we have our trachea. Here's our clavicles. Okay, here's our sternum. We have the aorta and great vessels. And notice it makes a loop here. So when we're looking at the chest x-rays, AP and lateral, you're going to have this knot. They call it the pulmonary arch or the aortic notch. or aortic knob. I've heard it called many, many things, but you'll be able to really see that on a AP or PA chest, and here you'll see it on the lateral also. And pay attention, the heart is located in the what? Anterior portion. It's directly behind the rib cage here, so it's anterior. So this would be another reason why we would be doing a PA projection, because we want this part, this front part of the chest to be closest to the IR if the IR were to be here. Okay, and here's your diaphragm. Notice it's a dome-shaped muscular organ, and it moves up and down as we breathe. And the other thing I wanted to show you was, look where the esophagus and the trachea is located. Right in here, here's your esophagus. Obviously, it's behind the aortic notch. But look, here's one of your bronchial tubes cut out so that you can see that there would have been another lung here. So what they've done, they've actually removed one of the lungs so that we can see all the structures of the mediastinum or the hilar region of the chest. Mediastinum or hilar region of the chest. And I believe that image in your book, I'm not sure if they have that in your book. Okay. So let's see if we go to the next one. Okay, so here we're looking, and we're going to be looking again at the mediastinum. We're looking at the chest x-ray. And we're looking here, again, we're seeing the right lung. We're looking at the left lung. And notice that there's a notch right there. That is your aortic notch, your aortic knob. That's the where your aorta comes up and it loops back down. So you're always going to see that notch right there. And obviously this is the shadow of the heart. Okay. So again, this is showing you on a lateral view of a chest x-ray that we have the anterior, posterior parts of the chest. We have the superior portion, and then we have the mediastinum itself. But notice that it is definitely, the heart is definitely in the anterior portion of the chest. General considerations here, upright position versus prone. This here is done prone, and the reason we know this, and I've already brought it to your attention one time, notice the gastric bubble right here. When you're doing something upright, a person is standing upright, there is always air in the stomach. And what this does, it gravitates and gets caught underneath the diaphragm. It's still within the stomach, but it's there underneath the diaphragm. So that tells us that this person was done upright versus this one here where you can't really see the gastric bubble. So this person was done prone, but you can see how the diaphragm is more superior. What happens when you lie down, you actually, all your visceral organs here push up on the chest and the diaphragm, and it causes all of this to go higher. So your diaphragm is a lot higher when you're doing a prone or a supine chest, because this actually spreads out and pushes up against the diaphragm. Okay, here's two views of chest x-rays. Obviously, these are patients very sick. Again, I just wanted to kind of slowly introduce you to some of this stuff. Obviously, this person has either had some type of procedure done. It's definitely a female. You have the breast shadow right there. This person has had some, obviously got some pneumonia or some other type of pathological condition going on here. It looks to me as if they've actually had part of the left lung removed, because there's no lung markings through the breast tissue at all. And this is the same person here showing you the areas here. Again, here's your heart. This is the upper lobe of that left lung. But we'll get to all of this in just a minute. Again, you can see that this was performed. You see that distinct straight line right there of the air, showing you that this was done upright. So just want to share a few x-rays. We're going to see a lot of them, so just be prepared. Here we've got what we call a pathology known as a pneumothorax. And what is a pneumothorax? So it's pneumo meaning air in the thoracic cavity. Okay? It's not in the lung. pneumothorax. It is free air in the thorax, in the thoracic cavity. So what we have here, we have an outline of some air right in there that is a different density, obviously, than the air in the lungs, as you can tell. But that's called a pneumothorax. It's actually air that is now trapped between the two linings of the pleural cavity. Okay, and again, we can look here. We can see it's got what they're showing here as a collapsed lung. This person doesn't have a complete collapsed lung because you still see lung markings on both sides. But if it were completely collapsed, it would be completely white over here. Okay, let's see. I was hoping that I had more of the anatomy. Breast placements here, obviously, we will have to be cognitive of this. We will cover this in our positioning, but you can see what the image of a breast can do to the appearance of the lungs. Here again, you see them right there and right there, and it changes the overall grayscale right here. Everybody see how much lighter this is right here? It's because the breast is there. And we have some positioning skills that we will introduce you to, just that we will be able to better see your costophrenic angles. As you can see, the breast here has been lifted up. And what we're doing that, because right here you can see it's hiding, and it kind of looks like they may have some type of fluid because it's lighter here. It's not got any air. Can't see any air in that costophrenic angle. Here, by lifting and separating the breast, you can actually see the costophrenic angles. And again, we'll talk about that, but keep in mind that this is something in the medical world that we have to do on a daily basis. We'll actually have to ask patients to help out with this and, take care of this problem, because we're trying, again, these little costophrenic angles, cardiophrenic angles are very, very important in a chest x-ray. General considerations as far as your breathing instructions. We want inspiration and expiration. I think your book's going to say you have to have a minimum of 10 ribs above the diaphragm when you have good inspiration. And you can see what happens if you catch them on expiration. And what we teach you guys is to have double inspiration, meaning that you're going to have them while you're talking and positioning your patient at the vertical grid, preferably standing. That is the preferred method for a chest x-ray. You're going to be telling them, I'm going to have you take in a breath, blow that one out. Then as I walk away, I want you to take in a much deeper breath and hold it. Do you understand? They'll say yes. So I'll say, okay, go ahead, take in your first breath, blow it out. And I'm walking away from the patient going to the console. And I'm halfway there and I'm saying, blow that breath out. And I take in a much deeper breath and hold it. That's giving you over expansion of the lungs, which is what we're after. We're wanting this expansion right here. We do not want this. Again, if this happens, you're going to have to do a repeat. And that's what we try not to do in radiology, creating unnecessary repeats. And again, look at this little circle here. Everybody see it. There's our little gastric bubble, our little friend. Here's our cardiac shadow. Everybody see that? Cardiac shadow. Here's your aortic knob again. As you can see right here, there's a little dark black coming down, and then you can see it doing its magic here, and it's bifurcating going into both lungs, and that little area is called the carina. So your trachea is anterior to the esophagus, and you have a bifurcation or a division of the trachea into your left and your right main bronchi, and you can follow it through as you read in your book, all the way down to the single ovuli, which is where your oxygen levels and carbon dioxide exchanges. Technical considerations, grid versus non-grid. I'm not going to mention a lot about that, but do know that all of our chest stands have built-in grids, and you can certainly see what a grid will do as far as to a non-grid. So we want to use a grid, and like I said, the majority of our systems in our clinical settings have built-in grid, so we'll always be using a grid. Now, it may change when we're doing portables. Just want to bring something to your attention real quick. Notice right here on this patient's left side, you can't see that costophrenic angle. There's a problem right there. This person has probably got a little bit of accumulation of fluid going on in this left lower costophrenic angle. So that's a good indicator there. Again, we can tell this one was done upright. You can see where there's a gastric bubble there underneath the left diaphragm. Definitely got some underexposure here. I would not think that this is caused by a grid. I would say that this is a pathological condition, but look at your grayscale, all your pretty grays on this side with the use of a grid. Over here with the non-grid, you get that high contrast. And remember, we don't like that high contrast when we're trying to do a chest x-ray because we're trying to get all the grayscales. You can see all these little white lines in here. Those are called vascular markings. Those are what you want to see. You want to be able to see those tiny little spider-like things going on in these lungs. That's telling you that you have got a good scale of contrast. Okay, here's our lateral general considerations with our SID. Our standard distance is always going to be 72 inches. It helps to minimize magnification. And obviously you can see this one done at 44 inches. This one done at 72. So we definitely do 72 when possible. Definitely on outpatient, the patients that are able to stand, we're always going to do 72 inches versus our 44 because it helps reduce magnification. Okay, and also I'll mention this real quickly on our PA, and we're going to cover this again, so don't get too overwhelmed. When we're doing a PA chest, we're reducing the magnification of the heart because the heart is anterior to the chest. So we're going to have the heart, the anterior part of the chest against the vertical bucky. And now the heart is close as it can get to the bucky, the vertical stand. So you're reducing cardiac magnification by doing a PA chest versus the AP because of the reduction of cardiac magnification. Okay, and here's the PA projection. I really want to get all into this, but I'll go ahead. I'm not quite sure how long I've been running. But let's look at this. This person are both in good position for our PA chest. One thing I warn you about, there's a little notch up here in this little top of your bucky tray. You see what happens when they're not able to put their chest that far up there as you're stretching and moving the bucky up. It brings the base of their head down over into the middle of your top part of your mediastinum. So if that looks uncomfortable for them, by all means, don't do it. Just have them look forward and kind of bring their chin down. But here we can see that the person is standing. They have their arms folded back. And what this actually does, you'll see different ways of doing this. But what the challenge of doing this, you're trying to pull this bone right here called the scapula. We're trying to move it laterally and away from off of the chest field, off of the lung field. So that's what this position helps us do with the hands put behind our backs. Again, you'll see several different ways of doing it. Several techs have their own way of doing it, but this is, again, he's going to be centered. This is your MSP. Your crosshair, your horizontal line is going to be at T7, the tip of the scapula, which, remember, we showed you that that was one of your landmarks, your inferior angle of the scapula. So you will feel on his back, and right there you'll feel the little bottom of the scapula, T7. Inferior angle of the scapula is where you put your horizontal line. The person is MSP. Okay. Again, this is a PA evaluation. We have our air-filled trachea. You can see it really well on this one. We have the apex of our lungs. There is your aortic arch. Remember, that's the top part of where it wraps back over itself. Obviously, we have the lungs. real pretty vascular markings of the lungs, which is again what you want to see. You want to see that spider-like network on there. You see your diaphragms right here. You can see the diaphragm. There's your costophrenic angle. Here's the other one. There's your tiny little gastric bubble. This is the heart. All of this is the heart right here. There's your aortic knob. This is the heart. Again, they're showing you how important the costophrenic angles are. So make sure on your image evaluation you want the apex. And again, you see this person has got a little bit of the apex above the clavicle. So that will tell you the body habitus. And also you see that we're including our costophrenic angles, most important. These are our PA with rotation. Sorry. Okay, and what they're telling us here is going a little further than I wanted to today, but at any rate, when you're doing your evaluation, it tells you that you should have equidistance of the sternoclavicular joints. And you can see right here, there's some open joints here, right? You see the little black area here? So where the clavicular end attaches to the sternum, there should be a joint space. I see them both on this one. When I get over here, you see PA with rotation. Look at this right clavicle. It's rolled over onto the spine, so it is closed, and this left one is pulled away. It's overly open here. So you can see that's how we check. It says equidistance of the sternoclavicular joints. And obviously this one is rolled over. He's kind of rotated towards the towards the left. So it brings it over towards the spine and it pulls the left one away. This is not what you want. You want equal joint spaces. That's what they're talking about right there. Your PA with your evaluation of your equidistance of the SC joints, open SC joints. You should not have a joint, the clavicular end overlapping the spine. I'm going to go ahead and throw the lateral chest in there. Lateral chest, he's going to notice his arm placements. He's bringing his arms up and out of the way of the apical region of the chest. This is called your MCP plane. So your MCP. And again, your horizontal line will again be at the level of T7, inferior angle of the scapula, or they call it the nipple line because it lines up perfectly straight with his nipples. So again, you can feel from the back, make sure that you stay MCP. Right here, your vertical line is MCP, and your crosshair is always going to be at T7 at the inferior angle of the scapula. And think about this. How many thoracic vertebrae are they? There are 12. So if you took 12 and you divide it by half, you're going to get what? 6. So that's where they're getting that 7 at. So they're trying to give you a midpoint of that 12 because you got 6 and 6. So they're going to say, well, let's do 6.5. Well, that's how you get your T7. T7 is actually going to be midway between your thoracic one down to your to T12. There's a marker placement anterior on the lateral. Perfect positioning. Little bit of light above the shoulders here. You can see it on the board. See where he's got his bucky tray. All this is aligned. See, it's lined up with your bucky tray again. But keep him MCP. And the one thing you want to do, you want to look from the back and make sure these two scapulas are actually superimposed. So you would put your hand back there and make sure that he's not rotated one way or the other. I usually go from the front here. You can see that both of these sides of his chest look completely superimposed. But we'll show you this in clinic. But this is very important that we start learning this information because the chest x-ray is one of your most prevalent exams. I would say 75% of your day you're doing chest x-rays. So we have to get to a level of perfection when we're doing the chest x-ray. Okay, Here we have what we're trying to avoid. We do not want our patient leaning backwards. We do not want our patients bending forward. We want them to stand perfectly straight. And again, that you can see what's going on here. And the one thing I'll bring to your attention is you see this set of ribs right here. That tells you that we have got rotation. You should not have any ribs behind the spinous processes of the thoracic vertebra here. This is an indication again of rotation, and this here shows you rotation. So we have a rule of thumb. Usually it's 2 fingers. If you have more than 2 fingers of rotation, you have to repeat it. If you have less, sometimes they'll let you get away with it and pass it. And that's, again, not our call. We're going to be working under the discretion of a registered technologist, and they will tell you, go ahead and repeat it, or that's good enough. Again, that's not our call. Here you're going to see the sternum. See it really well. Right here, you see the problem right here with the bending. It seems like we have underpenetrated right here. It's very white. Okay, so when you get on good and straight and you get those arms correctly positioned, you should get penetration up here. Okay, for your lateral evaluation, again, look how pretty all this is showing up. We have great collimation. There's your apex of your lungs. You have the air-filled esophagus, because the esophagus is located behind the trachea. You notice that these little black spots, those are your bronchi, your main right and left bronchi, as you're looking on in, as if it were a straw, and you're looking down the straw, because there are tubes running down and obliquely on the front. So when you turn them sideways, you're actually looking into the hole, into the bronchial tubes. We have posterior ribs. Those look really good. This is what we want to see. We want to see little to no rotation. We have the heart shadow here. You have the diaphragm, as you can see there. And again, we have our posterior costophrenic angles right there. This is your diaphragm. That dark, you got to have air. That's your air in the lung right there. Again, we want to make sure that we have the costophrenic. These are your posterior costophrenic angles. There's 2. Remember, there's 2 lungs here. So these lungs are completely superimposed. You see the sternum really clear. There's no rotation of the lungs over them. This is a very, very nice lateral evaluation, a lateral chest x-ray. Okay, guys, I want to stop here. And let me close this out. All right. Back to this. And we go out, close, don't save. Stop sharing. Sorry about all this. All right. I'm going to stop